Good afternoon, sisters. How are you? Great, great. Well, my name is Wanda Johnson, and I am an early stager, but I have a strong heart for my MBC sisters. I want you to know that, and I get to share that whenever I can. I am also about to be a 11-year survivor coming up. I still consider myself as surviving because it's an ongoing journey. This afternoon session is on NBC, particularly that which is in the liver and lungs, and it's going to be led by Dr. Michelina Cairo. Did I say that right? All right. And Pat Jones. Dr. Cairo, I got too tickled on yesterday because I said, let me pick up a magazine that I get at home and let me just kind of browse through this. They have an article on NBC talking a lot about the drugs that were kind of mentioned in the previous session. And I get reading here and I'm like, Dr. Michelina Cairo, a breast oncologist with Texas Oncology, Houston Memorial City. And I'm thinking, I know that name. Who is that? Then I picked up my other papers and I discovered, well, I'm going to be introducing her tomorrow. So I thought that was kind of neat that I just saw your name again on yesterday. And for those of you who have not heard the introduction about Pat Jones, she's a foot soldier is what I call her. She's been advocating since her very first diagnosis back in 1993. And then it was about, 5-6 years ago that she had a recurrence, and you would never, ever know it. We talked about appearance, but appearance, attitude, spirit, level of advocacy, all of that. Pat is the epitome, I think, of what it means to travel the journey that you all are on through this life cycle. So with that, I want to remind you that we are live streaming this session. For those who want to go back and review it, it's at coleman-houston.org. With that, I'm going to turn it over to Dr. Cairo.
All right, thanks everybody. I'm so sorry, I have a little bit of a cold. Let me get this taken care of. Okay, so I have liver and lung directed therapy for metastatic breast cancer as my presentation, but I guess I just got to liver, and then I suppose I felt fatigued here. So I'm going to start talking about liver. I'll move on to talk about lung, and then we're going to talk about sort of a special class of metastatic disease, the oligometastatic disease, and what the future might hold in terms of research for metastatic breast cancer. So the liver metastases. Why? Why does so much breast cancer tend to go to the liver? What might some of the symptoms be? What determines prognosis? Because everybody's prognosis is individual, so I'm not going to try and guess for anybody today. And then also talk a little bit, the most interesting part, about the treatments. Some of the indirectly applied treatments like chemotherapy, but really more focused on some of the things we don't talk about as much, which is the direct treatment, radiofrequency ablation, and transarterial treatment. Hey, ladies, welcome. So happy to have you. So why? The liver is an important site of metastatic disease because it gets its blood supply from two sources. It's got blood coming into it from the hepatic artery, and it's got blood coming into it from the portal vein. So you've got dual blood supply. You've got double the possibility that some of those traveling or circulating cancer cells might find a nice home. So it's just greater probability that you could land there. It's also a comfortable place for the breast cancer cells. And liver metastases are malignant tumors that have spread from another organ. So I have some patients who get alarmed when I start talking about other places in their body where they might have cancer, because they go home and they tell their spouse, oh my God, I've got liver cancer too. Oh my God, I've got bone cancer too. Oh my God, I have brain cancer as well. How could I have all these different cancers in my body? And it's limited reassurance, but it is a little bit of reassurance to that panicking patient that it is the breast cancer cells that move. And wherever those breast cancer cells move, they are still breast cancer. It is still just one cancer. So symptoms, some symptoms sometimes you can have no symptoms, none whatsoever. We just find it on scans. Sometimes people can have some pain in the right upper quadrant. Sometimes people might have jaundice, which is yellowing of the skin or the eyes. Some people might have elevated liver function tests. That is the AST, the ALT, the ALK phos, the bilirubin. Sometimes these tests are a little elevated. Now, these tests can be elevated for a whole variety of reasons. You get a cold, they're elevated. You take chemo, they're elevated. You celebrate the holidays, and they're elevated. Sometimes people will have fluid collection in the abdomen. That's ascites. And some people might have decreased appetite, usually based on some of the above. But these are not all of the symptoms. A woman may have none of these. It's one of the most common sites of breast cancer metastasis, so its prognosis is sort of tied in with the rest of metastatic breast cancer. It definitely depends on the sensitivity of the tumor to therapy and how quickly we can get new therapies to patients. And the treatment options will depend on the hepatic dominance of liver metastases. Is it the one and only site? Are there a lot of tumors in the liver? Are there just a few? Are they big or are they small? Is it one site and there's also metastatic cancer in the lungs, the bones, even the brain? And so those are all questions that help to determine the treatment. So treatment. Number one, most important, is the systemic treatment. And by systemic, I mean the pills that a woman takes or the IVs that she gets. The medicines that are there to target all of the cancer cells, no matter where they are. But some people have had the experience where the scans come back and your doctor says, well, these results are mixed. You know, the lungs are doing okay. The bones are doing okay. They're even getting smaller. But there's a liver mass that's getting bigger, about 0.5 centimeter bigger. Second liver mass that's getting bigger. Now, what do we do in that situation? Maybe the medicine, the systemic therapy that she's on, maybe it's doing well for her. Maybe it's really tolerable. Maybe it's a pill and she doesn't have to come in very often. Maybe you're really motivated to not switch away from this medicine. Are you obligated to? Well, maybe you are and maybe you aren't. Are there other options? That's where the liver-directed therapy comes into play. If at the end you want me to get back and talk about new systemic therapies like hormonal therapy or targeted therapies or immunotherapy or some of the things I talked about in the Cure magazine article, I would be more than happy to. But for this talk, I thought I would talk about liver-directed therapy, radiofrequency ablation, and intra-arterial. So I've got two pictures up there. And the top one with the guy who sort of looks like he's massaging the liver, that is the ultrasound probe. Now, obviously, this is a picture of a liver, and you don't actually remove the liver from the woman's body. But it is a cartoon where they're using the ultrasound probe in order to see where the liver mass is, and then putting in a special radio frequency device that will shoot radio waves at the tumor and zap them. Now, obviously, that is only going to work where you put it. It's not going to work on any other part of the liver. It's not going to work on any other part of the body. So it's sort of a supplemental kind of treatment, much like for our early stage sisters or when you were early stage, radiation therapy was a local treatment. It wasn't going to work anywhere where you didn't shoot it. So radiofrequency ablation was one of our first treatments, but it's a little limited. That tumor has to be visible by ultrasound, and not all of them are. That tumor has to be accessible with that big, long device, and it has to be in an area where the radio waves are far enough away from other organs. It can't be right next to the portal vein. It can't be right under the diaphragm. It can't be right near the heart. It's a little limiting. So it didn't, the reason it has caught on but it didn't catch on like gangbusters. So what would be the other option? Intra-arterial. So up there, I've got a picture under my liver-directed therapy of a blood vessel, and I've got little tiny molecules shooting out of a catheter and through the blood vessels. And so intra-arterial, there are two ways to do this. One is with chemotherapy, that's TACE. One is with radiotherapy, and that would be TARE. So this is a little bit of a busy slide, but I am going to break it down and go through them all. So TACE, transarterial chemoembolization. This is where you take a liquid drug, a liquid chemotherapy, like a small dose of adriamycin or a small dose of another drug like that, emulsify it in some oil, poppy seed oil. Who knew? I didn't know until yesterday. Or you can coat microspheres with the drug, and then you send the catheter up through the liver circulation, and you say that blood vessel is going to that tumor, and then you just shoot it like you spray a water hose at your brother. Psst, right there, that's where I want it. Psst, right there, that's where I want it too. This is a little bit easier to manage because you're not going from the outside, you're going from the inside. And believe it or not, interventional radiologists are really quite gifted at navigating the tricky blood vessel system of the liver using fluoroscopy. So TARE uses yttrium-90, that's just nuclear. So yttrium-90 transarterial radioembolization. So these are little tiny spheres, little tiny beads, 20 to 30 microns, microspheres. Like if I dropped one on the floor, I couldn't pick it up. And they can be made of glass or resin. And then the Y90 decays at the microsphere. It doesn't travel through the body. It doesn't detach. It decays at the microsphere and it emits not X-rays, but beta rays. And these beta rays are real short. So if I were a microsphere in a liver and you're the next cell near me, my beta ray can only go about that far. I can hardly even reach you, and I certainly can't reach all the rest of you other lovely, healthy liver cells in my liver room. It doesn't go very far, arm's length away, no further. So it's really a short distance. So how does it do anything? Well, the liver tumors have lots of blood vessels. And so the microspheres tend to collect in higher numbers in the tumors than they do in regular cells that have a normal number of blood vessels. So if you had lots of me's with our arms out, we could really do a lot of damage, but just in that one area. So the microspheres have been really cool. Officially speaking, breast cancer label is off use, but it is off-label use, but it is supported by very strong data. So risks and benefits of intra-arterial embolization. This is kind of a cool picture. So this is the liver. You can kind of see the blood vessels on the contour of the liver. This is the inferior vena cava, and this is a catheter that's coming up and is going through these different segments to ultimately to where a tumor will be. But these are all the different blood vessels. And so you can see you just make a right, a left, and two rights, and you're where you want to be. Really minimal toxicity. Grade 1 to 2 toxicity, which is tolerable, or maybe you have to take a couple of pain medicine in 88% of cases. It's an outpatient procedure, and it's minimal downtime. The only incision is an incision in the femoral vein, which is where the artery, which is where they access. And that's, I mean, anybody who has had a cardiac cath or whose spouse might have had a cardiac cath, it's a whole lot better than the alternative. I went back. Okay, patient eligibility. This is very, very individualized. 100% individualized when you think about using liver-directed therapy. I gave kind of a general example just as my case presentation, but generally speaking, when I talk to my interventional radiologists, they're looking at less than half of the liver being involved, but ideally less than 25% of the liver being involved. The liver is fantastic at regenerating itself, but you don't want to go and beat up 75% of the liver. That's a tough thing to ask the liver to come back from. So you can beat up less than 25% of the liver, and the other 75% is usually going to keep doing its job, but that's an individualized decision too. If there is stable disease outside the liver, that's okay. That's always been sort of my gut feel, but it was really reassuring in preparing this presentation to see that if there's stable lung disease, stable bone disease, and you're just progressing in the liver, that the data supports the use. The better the performance status of the woman is, the better her treatment outcomes are going to be. That is universally true with cancer treatment. And there's some evidence that the radioembolization might be better than the chemoembolization, and it really has been a lot more popular. So that's why TARE possibly better than TACE. So another way of looking at the microspheres, here I've got a person on the table. I apologize, this is a man. I looked for a woman, but I couldn't find one. That's sexism in medical diagnostics there. So here, they are accessing this person's femoral vessels, going up through the blood vessels, and then here is the catheter going into the blood vessels, and then accessing the part of the liver that is most relevant. And from the outside, that's the procedure right there. I mean, that's just a little spot open on the leg. So the microspheres are injected into the liver artery that supplies the blood to the liver tumor. There is always a sham procedure that's done ahead of time to make sure that you can get there and to make sure that it's safe to put the spheres in. When the catheter is in position, they release millions of microspheres and they go directly to the tumor. The spheres get trapped in the tiny blood vessels around the tumor, and they give off enough radiation just at arm's length to kill the tumor cells, but not to affect the rest of the liver, and the surrounding healthy liver relatively unaffected. The spheres are only radioactive for a short time. After 2 weeks, only 3% of the initial radiation remains, and at 4 weeks, it's 0. And so it's safe to hang out with grandkids and sleep with spouses and use the same facilities as everybody else immediately after the procedure. I really liked the pictures of the Y90 microspheres. So here, finally, I have a tumor. So here I have the catheter coming up and going directly into the tumor and releasing the microspheres into the tumor. And so here they're putting out their beta radiation, and you can see if you've got them all right next to one another, they can create a lot of damage right here, but not right here. The bottle with the microspheres, and then sort of a cartoon of what it would look like to have the microspheres all inside the blood vessels of the tumor. As an alternative, transarterial chemoembolization. So this is not the spheres with the radioactivity on them. This might be spheres with chemotherapy on them, or simply a bolus of chemotherapy. It's a liquid drug. I gave you an example of doxorubicin here because that's the one that I used to use back in the day. And it's a similar process where you find the artery that you want that goes to the tumor that you want to do, and you do it, and then you do the next one, and you could do the next one. Chemoembolization, you don't usually do all three at once. Yes?
So do they use the sonogram while they're doing this?
Yeah, they use something called fluoroscopy. Yeah, they're doing it under imaging. And so what it looks like to them is going to be more like that kind of picture. But they know, without the colors, but they know what they're looking for there. Okay, so for the summary for the liver portion of this, the treatment of liver-dominant metastases, very, very individualized. This was just sort of a really high-level overview. It almost always begins with systemic treatment. That's treatment for the whole body: chemotherapy, immunotherapy, hormonal therapy, HER2-directed therapy, directed at the susceptibilities of the cancer. But under certain conditions, somebody may also get liver-directed therapy such as radiofrequency, chemoembolization, or radioembolization. Lung metastases. All of the blood in the body flows through the lungs to be reoxygenated. 100% of it. So the cancer cells that are in the circulation, also have have a probability of finding a spot in the lungs as well. Greater chance that the cancer cell could enter that organ. The symptoms of lung metastases really vary from no symptoms to shortness of breath, pleuritic pain, a cough, could be non-productive. Signs, some women will have a lung mass on their CT scan or their chest x-ray, sometimes fluid buildup between the lung and the lining of the lung of pleural effusion, or another way that it may spread in the lungs is lymphangitic spread, which sometimes just looks like congestion and can mimic the appearance of infection, but usually has more symptoms. So treatment, again, systemic therapy, mainstay of treatment, but what if a woman needed a little bit more? So then we've got local therapy. There was a time when we would do surgery on these lesions, but thoracic surgery is nothing to sneeze at. It is a tough thing to consider undergoing. And so it was not something that we wanted to do for a lung mass that was, growing a little bit while the rest of the masses were remaining normal. It was something that we considered if it was the only site of metastatic disease. And even then, we weren't so thrilled with our outcomes. So what about SBRT, targeted radiotherapy? In the era of targeted radiotherapy, surgery has become significantly less popular. I'm afraid I didn't bring pictures of SBRT, but SBRT uses a special targeting seed into the tumor, and then it uses concentrated radiation to go directly to the tumor. And it's 1 or 3 treatments. So it's a really short course. It is designed not to affect the rest of the lungs, and it can be done in various places in the lungs. So what's coming up next? Because we've had SBRT for years, we've had TACE and TARE and RFA for years. What is coming up next? What's really going to be exciting? So the San Antonio Breast Cancer Symposium is in December of every year. And this year there was a talk about the role of radiotherapy, potentially in the future combined with immunotherapy in oligometastatic cancer. And this is the rest of this talk is adapted from Dr. Weisschenbaum's talk. So radiotherapy, by radiotherapy I mean radiation therapy or X-rays that are delivered at the tumor. For immunotherapy, these are medications that harness the body's immune system to unblind the immune cells, the T cells, to the presence of the cancer and to allow it to attack the cancer, because the cancer is really good at putting blinkers on the immune system. Like, don't look over there. Just keep your blinkers on. Just don't look over at that cancer cell right there. And oligometastasis is one or a few sites of distant cancer, and that's cancer outside the breast or the lymph nodes. We're understanding now that metastasis is a spectrum of disease. It has to do with the number of sites, and it has to do with the rate of progression. And our patients are all over the spectrum. And so it's very individualized, this treatment, but there may be a subset of patients that are all the way over here on this end of the spectrum that might have limited disease that could potentially be curable. And wouldn't it be worth finding out who they were? And so they are planning a trial with for a cytoreduction with systemic therapy. That's where you will reduce the overall tumor burden, but following it by metastasis-directed therapies that already exist, radiofrequency ablation, TACE, TARE, SBRT, in order to reduce the development of resistance. So is oligometastasis or limited metastatic disease different from polymetastasis? There's some research that suggests yes. This is sort of more of a hypothesis-generating slide, where we've got some lung metastases in breast cancer patients. And when you had just a few lung metastases, my patients are on the blue line. And when we have a lot of lung metastases, my patients are on the red line in terms of survival. I don't want that line to go down. I want it to stay up as high on the top of the graph as possible. So is there a difference in those tumors? When they take the tumors out, and they do these things called heat maps. And this is where every gene is, every sample goes across in the column, and every gene goes down the side. There's like 1,000 genes on this page. And when the genes are turned off, they're red, and when they're turned on, they're green. And what you do is you just kind of stand back and you look at it and you say, yeah, there are some differences. You know, from the tumors that came from the patients who ultimately did poorly, there were genes in the middle there that were turned off. And when you looked at tumors from the genes from the patients who ultimately did well or better, those genes were turned on. So what are those genes? How do we get at them? And what do we do about them? So there was a clinical trial recently, and so their hypothesis was that if they use ablative local therapy, they're talking about radiation therapy, chemoembolization, hepatic embolization, that kind of thing, to all the visible lesions after systemic therapy, that there could be meaningful improvement in survival. It's a phase 2 trial, so everybody got treated, and the plan is to roll over to a phase 3 trial. And they're looking for better overall survival. The patients that they included were metastatic breast cancer patients. At first, they were very, very strict, and they had less than or equal to 3 metastatic sites. And then later on, they expanded it to 5 metastatic sites. They were really looking for early patients. All of the sites had to be amenable to radiation therapy or surgical resection. Each individual metastatic site had to be less than 5 centimeters in size. The local disease, the breast disease, needed to be controlled either with surgery or radiation. And they had to have gone less than or equal to 4 months on the first-line systemic therapy without progression and needed a performance status that was good. They accrued all of their patients, which means this data is actually going to come out sometime in the next 12 to 24 months. So they accrued all of their patients in the phase 2 trial, and they will be opening up a phase 3 trial. Yeah, which that was the most important thing on there. I know they say 100% accrued. I'm like, go you. What's next? So what's next? Phase 3 trial. And so this will be an exciting option to change physicians' mindset about metastatic breast cancer, from being a chasm that you cross, that you can't cross back, to part of the whole spectrum of disease. And maybe we can go over here and bring people back. Maybe we can go over here and bring people back. How far can we go? And can we push ourselves further than before? So more research is needed. As soon as I see phase 2 trial accrued, I want a phase 3 trial, and I want the results like yesterday. Participation in clinical trials is always greatly appreciated. It's very important to us, and I appreciate every single woman who's ever participated or thought about participating. But so many questions remain that still need to be answered. Okay, I'm going to hand it over. There you go.
Oh, I have a big mouth, so I never know. Well, I don't have to introduce myself again. I guess my name again is Pat Jones. And I want to be very brief. I just bring you up to date on actually, I was originally diagnosed in 1993 with breast cancer. At that time, I was a stage 2. I did go through having a mastectomy immediately because I'm a little vain. I did not want to wake up lopsided. And so at the same time, I had reconstruction of the trans flap. So in the process, I got a little tummy tuck. I did have 6 rounds of chemotherapy. I was on a Remedex for 5 years. After that, it seemed like I was doing quite well, as we think. And okay, I've beat this thing, right? Well, in 2003, I went for a regular routine checkup. And something was discovered, but the radiologist I fell through the cracks, and the radiologist failed to let the physician know. So it went another year before I went back, and the way God plans things, my doctor's nurse is a friend of mine, and she called me. I don't think at that time they had HIPAA. She said, you might need to check your records and look, this radiologist failed to inform your doctor that it was some abnormality. So I went to my doctor, and sure enough, my cancer had metastasized to my lungs. They did a biopsy, and of course, yes, it did show that my cancer had metastasized. Just a little side note, guys, this was in 2003. And what miracle drug came out? Herceptin. So for me, Herceptin is a lifesaver. I do have few small nodules in my liver. Right now, my oncologist is not too concerned. She monitors them, but it's nothing big of a concern. The major concern that she's been looking at is my lungs. Last year, I think I have to write stuff down because I'm bad with dates. May of last year, my tumor markers did go up. And so she added Herceptin with Tyker, if I'm saying it correctly. And it's an oral drug. You take it's like being on birth control. I'm like, oh my God. You take 4 of these huge pills for 28 days, and then you're off for 7. So very minimal side effects, and so far I've been doing quite well. I get, of course, an echo because it may eventually damage the heart. And I've been blessed, minimal, no damage. One thing I do notice, I do get short-winded. That may be part of age too. We get younger, so we move slower. But part of it, I am short-winded a lot. Not that often. I'm learning how to listen to my body, as we talked about in the big room, and pay attention to myself. I'm glad you mentioned research and getting a part of clinical trials. And I think that's so important, especially me with African American women. We don't get involved with clinical trials. And of course, with the cells dividing and differently, they need more testing and more of us to step up and volunteer, for clinical trial. If it hadn't been for research and clinical trials, Herceptin would not be a lifesaver for me, or some of the medications that you guys are on. So I really advocate that a lot. I really push that a lot. And I think it's really been by the grace of God that I'm still here. And I'm grateful for the researchers, for the physicians that come up. I can't wait to see what this new clinical trial is going to be. I've been wondering, and some of the questions that I hear asked on a lot of NBC patients, when's the next drug coming out? What clinical trial is being, what's in it for me? What happens when, like I say, Herceptin is working, it's keeping me maintained. Now I'm on another drug. So what happens with this? One of my concerns right now is, and I'm bringing this up because it affects me, the cost of medication and treatment. Just for example, the Tyker, it's like $2,000 for once a month. With assistance, there are programs out there. I advise you to research, get programs, get involved. Outside at the table, they did have information on where you can get research. I'm doing that right now for myself because one of my copay assists, funding has dropped. There's no funding right now. The closest thing I could get is $200 a month. I'm sorry, but my CPA and accountant told me in the budget. But we have to be proactive for ourselves. So as an NBC lung and liver patient, I am proactive. I advise you, I push you, I urge you to be your own advocate, to talk to your physicians. Okay, this is the problem I'm having. This is what's new. What can I do? Is there a clinical trial that I can get in? You talked about that. What can be done? Talk about your symptoms. Some days I'm thinking I'm just lazy and I'm feeling it, but it's really I'm tired. But it's a different kind of fatigue. It's really different. You feel different. So it's important that while you're here, share names, talk to each other, because we know how we feel. Nobody can tell unless they walked in your shoes how we feel. A physician can't tell unless they're another MBC patient, if they're experiencing that. So if we don't tell them all of our symptoms and what's going on and what's working and what's not working, where's the future? What's going to happen? So I urge you to get involved. I urge you to speak out. I would say that I changed my journey. I don't say I'm going on an NBC journey anymore. I say this is a dance. Yeah, I do because I do a dance. Because it is a dance. And somebody said, well, your dance must be the jitterbug. Because I'm back and forth. We don't have a regular line dance because each of us is in a different routine, in a different cycle. So we don't have a line dance. We may have a waltz some days. We may have the bop where, okay, I went to the doctor and my scans and everything looked good. Then I went back in 3 weeks and they did the month, and what happened? So this is my dance. And again, as I end, I just urge you guys, really ask questions while you're here. Get as much information as you can get. I mean, I'm soaking it up. I am so grateful for these conferences and the webinars that we had, because you didn't hear much about NBC. We were like in the closet in the background. They didn't talk much, didn't talk much about us because we look so good. And everybody in here, y'all don't look sick. What do you mean something's wrong? What do you mean is something wrong with your lungs? Well, you're not on oxygen. But that's the first thing we think of, and I hear, but my lungs don't hurt. We have different symptoms. I do. So thank you again for giving me this opportunity. And I'm going to turn it back over if anybody has any questions.
All right, I'm going to come on up here because there's no reason to sit back there. Pat and I can sit together up here. Yeah, what's up?
Well, you were talking about the lung trials, and you said that it's made for people who have maybe 3 to 5 metastasized sites. Does that mean within the lungs, or do you mean if they have bone, if they have liver, if they have brain? When you said sites, do you mean sites within the lung, or do you mean outside the lung?
It was total.
So if
Yeah.
you have more, so if you have a few in the lung, but you also have a few in the liver and a few in the bone, that you add all those up, it's
Yeah.
not just the lung.
It's not just the lung.
Okay.
Yeah. So that particular trial is designed for for few metastatic sites, because what they want to do is at least from your doctor's perspective, we're thinking stage 1, stage 2, stage 3 still curable, stage 4 boom, the floor drops out from underneath you. Maybe it doesn't. Maybe in those very early stages of stage 4, where there are just 1 or 2 or 3 sites
Sites meaning
throughout the body. So for example, I've got a young lady, she's 32. She came with about a 3 centimeter mass and probably, 3 or 4 lymph nodes. But then when I did her scans, that's where I found the lumbar spine mass. But she only had 1. And so even before I went to the San Antonio, I was thinking to myself, is there more I can do? Or do I just step off, the cliff here and say, oh, I'm so sorry, all is lost? No. So, and this just further supported what we were doing. She's not involved in this trial because I didn't have it open at my site, but thinking about the questions this trial is asking, we put her on systemic therapy. She was stable for the first couple months. We went ahead and did radiation therapy to the lumbar spine. And now we're going to go back and we're going to take out the primary, actually. So we're thinking, is there a weird and circuitous route to maybe curing her? And could I then make a difference for other women like her before the cancer cells become resistant to my systemic therapies? Any other questions? Anything you want to know about sort of yeah, go ahead. Yeah, do it.
back back to the sites.
Yes.
Because you also said after systematic,
You got
hormonal
it.
chemotherapy, then you move into. So if you do have other sites, but all the other sites are not growing or static or not,
Yeah.
but the lungs or liver, so does that still count as sites?
No, it's got to be total. It's got to be total number of sites. It did make
They're
sense.
not being aggressive or growing like
They still, for the purposes of that clinical trial, they still count.
okay.
Yeah, they would still count in terms of inclusion for the clinical trial. But then in that case, that's a little more like a more common situation I see where my patient has bone and liver mets, for example. And the bone mets are really stable. I've got her on a good course of anti-hormone therapy, maybe a CDK4/6 inhibitor. Bones have gotten really stable. She's on Xgeva as well to stabilize the bones. Things are going well there. And I do a scan. A liver mass is 2 millimeters bigger. I'm like, let's do a short interval follow-up. 6 weeks later, we do another scan. The liver, the two or three of those liver masses are now, a half a centimeter bigger. And I'm like, okay, I believe it. But man, CDK4/6 inhibitors are well tolerated. She feels good. She's got a good appetite. She lives an hour and a half away and doesn't want to schlep into my office all the time. So what could I do? In her case, I could consider doing the microspheres, the Y90 spheres to her liver masses and see if I can just treat those and then stretch out the amount of time. And for me, it serves two purposes. Number one, I'm doing a liver-directed therapy. I'm keeping her on her really well-tolerated therapy. But then the question is, why did the liver masses grow and nothing else did? Those liver masses were becoming resistant to whatever CDK4/6 she was on. They were becoming resistant. And so I was going to have to change therapy to try to get rid of those resistant clones. Well, what if I could get rid of them a different way? What if I could zap them with radiation and then I don't care what they're resistant to? Zap them with radiation and that way I can do that. And I can sometimes get a lot more time out of that. And I'm always looking for time because I'm always looking for when's the next great thing going to come out. Any other questions? Otherwise, I can talk about a couple of the next great things. Is there an interest in this room in HER2-directed therapies? Yeah? Okay. So, yeah, HER2 positive. So, at the San Antonio Breast Cancer Symposium this year, there were 3 amazing clinical trials presented for HER2-directed therapy. And they're all after somebody's progressed on Herceptin and after somebody's progressed on Kadcyla, an antibody drug conjugate. After that, again, the floor would drop on underneath us and up, what was next? 3 really exciting things coming. One is called Enhertu, and it's been FDA approved. It's a lot like Kadcyla, where it's an antibody drug conjugate. It's got the HER2 antibody sort of driving the truck, and then in the bed of the truck, it's got 8 chemotherapy molecules. So it's got GPS in that truck. It's got HER2 GPS. So it's going to drive to those HER2 cancer cells wherever they are in the liver, lungs, bones, and it's going to drop off its chemotherapy right there. And it's got 8 chemotherapy molecules, which might make it better than Kadcyla, which only has 4 chemotherapy molecules. And it's great. And in the clinical trial, 10% of the patients had brain mets. So it's got data in patients with brain mets as well, which is super exciting. And I hope they're talking about it over there at the brain met. So if you've got to roll, go roll. Don't worry about me.
I actually have 2 negative.
Okay.
I also have bones, so I
Rock on out, lady. Yeah.
I was going
Yeah, go ahead. Go ahead. Circulate. Don't sweat it.
We have some people with negative.
negative and bone.
Negative and bone. Okay. So for my triple negative patients, yeah. So for just to wrap up my HER2 positive, there is a new oral drug that's coming out. It's called tucatinib. You're taking lapatinib right now, that tight curve, it's going to be tucatinib. And what's great about tucatinib is that it gets into the brain and it has less diarrhea. And so I had a nurse, I had a nurse who presented with brain mets in the ICU. Everybody was going to give up on her. But no, she had HER2 directed therapy and got on and then progressed. We kept doing stereotactic radiation to her brain. I mean, we must have done it 25 times. Yeah, and she just kept progressing. So she went on the clinical trial with tucatinib, and she was stable, great quality of life, living at home, 18 months on tucatinib with brain mets. Yeah, she's fine. Yeah, I mean, you know, she doesn't work anymore, but that's more about the fatigue, really, than her mental capacity. Her mental capacity is still very sharp. It's really more about the fatigue and just like, you know, what being in the ICU for a month took out of her. It took a lot out of her. So tucatinib, I was really proud to have had a patient on that trial, and that's really exciting for my HER2 positive patients, many of whom will develop brain mets. The third one is going to be margetuximab. So margetuximab is going to be a new HER2 directed therapy. It's even better binding than trastuzumab is, Herceptin. So 3 drugs that are going to be FDA approved this year. One of them in HER2 already is. So really exciting.
I have read that if you're terminal, which stage 4 is considered terminal, and there's a drug still in clinical trial and it's working, it's the last phase and you're showing it's working, as a terminal patient, you can go ahead and start taking that drug without FDA approval.
It's called the right to try, and you have to get permission from the drug company. I have not yet had success doing that.
Yeah, I read that it was signed into law.
Yeah, but they're not the drug companies sometimes have reasons why they can't provide it, because they're making it in very small batches, you know, just enough to support the patients on the clinical trial, and so they may not have extra. And this was the case. I tried to get margetuximab for a patient of mine, and it did, and she wasn't able to get it because they just didn't have enough drug. And so I've not been successful in getting it. There are compassionate use programs, which are a little bit more supervised, and you'll have a little bit more, and we've had a little bit more success with in the past. So for example, tucatinib has not been FDA approved yet, but at the end of January, the drug company opened up a compassionate use program. There's a ton of paperwork. There's a ton of monitoring. That's okay. We're used to, I mean, I do clinical trials all the time. I'm used to paperwork and monitoring. It's all right. Yeah. And I got Piqray on compassionate use before it came out as well. So usually in that gulf in between the paper's been presented, everybody's excited about it, when's the FDA going to act? That's where compassionate use comes out. I'm a fan of compassionate use because there's paperwork and monitoring. Because these medicines have to be used safely. Piqray, for example, causes significant high blood sugar, and people have gone into diabetic ketoacidosis and passed away from DKA. So paperwork and monitoring.
Because I was tested positive for Piqray.
Oh, for the PIK3CA. Yeah.
And, but I'm not on it yet.
Okay.
I'm unslowed and it's working.
Hey.
That's my next one is Piqray.
Yeah.
But diabetes runs in my family.
Oh, but you're not yourself diabetic? You're a good candidate.
My mom, my brother, uncles, all that have that.
Okay.
And so I just didn't know if that was a factor in it.
It's a factor in our thought process. I don't put my existing diabetics on Piqray, but my non-diabetics, I put them on, and we do very close glucose monitoring. And even most of my non-diabetics do end up temporarily on a diabetic medicine. Piqray wears off very quickly, so it does not make my non-diabetic patients diabetic. It just raises the blood glucose for the time you're taking the medicine. And it's an on-target effect. So anything that's going to affect the PIK3CA pathway is going to increase blood sugar.
Is that mentioned in your article?
I don't think they asked about the PIK3CA in that article. They were asking about the CDK4/6s primarily in that article. Piqray was sort of just coming out then. Yeah, so it is. There's always something to watch out for with each one of these medicines. I mean, Xeloda's doing great for you. Xylota, if you have a DPD deficiency, you can get terrible life-threatening diarrhea. So there's things that can happen. There's things that can happen. And we just watch out for them. So
You lose lots of weight.
you lose lots of weight.
But you have no nutrition is absorbed from your body. It just goes right there.
When you have the terrible diarrhea. Yes.
It is terrible.
Yeah.
It is terrible. Yeah.
Anybody else with questions specific?
What'd you say?
Is there a treatment?
Is there
for
a
the
treatment for the diarrhea?
Oh, well,
They tell you,
We decrease the dose. I'm very aggressive about decreasing the dose of Xylota. I mean, Xylota is unique because it's a prodrug. So you can't just swallow chemotherapy because then you're treating your mouth and you're treating your esophagus and your stomach. And I don't want chemotherapy in my stomach. So it's a prodrug. It has to be absorbed by the blood and then it has to be activated by the liver. And everybody's liver is going to be a little different about how it activates Xylota. And so I have a very low threshold to adjust the dose. Standard dose of Xylota is usually going to be about 4 pills twice a day. Most of my patients are on 2 twice a day.
I'm on 3
You're on 3, so there you go.
for 2 weeks, and then I'm off.
Yeah.
For a week.
Yeah.
Those 2 weeks, I don't like meds.
Oh, because of the diarrhea.
I just if I'm gonna eat,
Yeah.
I can leave the house if I'm not gonna eat.
Mm-hmm.
But like going to, with my friends out to eat or anything,
Mm-hmm.
the week that I'm off,
Mhm.
I'm okay.
Yeah.
But those 2 weeks, get it. And I have to. I'm on what's brat, bananas, rice, applesauce, and toast,
Mm-hmm.
and that's just something to absorb to eat because nothing else. Everything else is worse. So,
You're in the top 10% of Xylota sufferers. I'm sorry.
I have no taste buds.
Yeah.
So I have to either oversalt
Mm-hmm.
or hot sauce
Mm-hmm.
or something really spicy
Mm-hmm.
just to taste it.
Yeah.
Yeah. So when people say, "Where do you want to go eat?" I really don't care.
You're not just saying that.
Because I'm not
Yeah.
going to taste it anyway. So.
For the life-threatening diarrhea, which is very rare, I have maybe 1 per year. There is a rescue medicine called Vistagard, but it has to be given within the first 72 hours of the symptoms. But it is truly a life-saving medicine. It's not going to be for you. You don't have the DPD deficiency. You'd know by now.
And I just wanted to make a comment. Pat talked about being advocates, and we are our own best advocate. Nobody can do it better than we can. And there are a lot of different options that we have. And I know that you had a question about advocacy, and maybe that's where we met. I'm not sure.
I think so.
I'll probably mess up all the CD, but the DOD, their breast cancer research program, and they utilize consumer advocates, survivors, co-survivors, to participate in the process of reviewing the applications for the new drugs.
Mm-hmm.
And it's in those settings that as survivors and as advocates, we get to bring issues and we get to bring concerns. Well, this looks good, the science looks good, but what about the devastating physical side effects? What about the financial toxicities? What about? So again, looking for different options and what you can do, that's an avenue. And my work for about 10 years was facilitating support groups and hearing the various stories and the devastating effects and so forth. So that was an avenue that I chose to be involved in, to go and represent the issues of those that I was involved with, and to be able to share it with the scientists, because many of them, I'll say many of them, but I know that some of them said to some of the advocates there in the room, We appreciate your comments because we don't hear that
Mm-hmm.
very often. We're in the lab, you know, and so to hear us talking about those things helps them. If just that little moment, they become more aware of what the result could be for the patient, you know. The science is great and it works. And I was really excited because I'm hearing a lot of the terms and things that I've heard a couple years ago about research being done. And to hear that some of those same mechanisms are now being made available,
Yes,
it's like,
yes.
yes, it's paying off. It takes time.
Mhm.
It really takes time. It's a you know, a process. Everything is a process. But to be able to hear that, okay, it's here, it's close, you know, it just makes a difference and helps to reaffirm that what I'm doing is right. Even if my voice is just a little voice, it's making an impact.
Right,
So,
right.
yeah. Because many times we don't know of the various avenues of advocacy that we can be involved in. It's either
It seems like
legislature or.
I take more medications for side effects than I do for the chemo.
Yeah.
Yes.
And I really
Yes.
Yeah, I believe it.
And they change. What, that one didn't work, well, let's try this one, you know, for the side effect.
Mhm.
But we're continuing on with chemo because it's, you know, working. So what do? Do you want to stay at home for 2 weeks and get, you know, see some decrease? Or do you want to just stop? I mean, what's your choice? So.
Qualitative.
We'd like to give you better choices. That's what research is about. It's about better choices.
Yes, yes. Yeah, it is. And this is my third chemo to try within a
Hey.
year.
Oh, okay.
It's Soloto.
Okay.
Soloto. And I take it Xgeva.
Mhm.
So it's working right now.
We are out of time. I want to